All right, so good morning and welcome to the PHFA Certificate in Elder Service Coordination Program. Today's topic is promoting independence in elders, and these webinars, in conjunction with specified sessions at the PHFA Housing Services Conference, will enable you to be eligible to receive a Certificate in Elder Service Coordination, which will be issued in partnership with PHFA and the California University of Pennsylvania Rural Communities Institute. I would like to introduce our presenter this morning, who is Dr. Janet Ann Melnick. She holds a PhD in Human Development with a specialization in social work. Prior to working on her doctorate, she was in clinical practice and administration in local agencies that specialize in work with the elderly for over 15 years. Dr. Melnick was the original supervisor of the Protective Service Unit for the Lackawanna County Area Agency on Aging. After leaving the AAA, Dr. Melnick was the Director of Rehabilitation Services for Telespond Senior Services. In that capacity, she was responsible for the administration of 2 adult day services facilities, a CORF coordinated outpatient rehabilitation facility, in-home respite services, and family caregiver services. Dr. Melnick was one of the original grantees for Robert Wood Johnson Dementia Care and Respite Services Project. At the end of that grant demonstration project, she was invited to become a consultant for the RWJ Foundation Partners in Caregiving Program, which funded and mentored adult day care program across the country. Dr. Melnick was the assistant coordinator of the social work field program at Marywood University prior to moving to Penn State. She has been a faculty member in Human Development and Family Studies, HDFS, at the Pennsylvania State University, Worthington-Scranton since 2000. She is a senior instructor and also the program coordinator and field coordinator for the HDFS and psychology programs on the Worthington-Scranton campus. Her primary teaching responsibility is in the gerontology and the internship components of the program. Dr. Melnick's research has been predominantly in the area of rural home and community-based services to the elderly. She has been the primary investigator for 2 grants from the Center for Rural PA in this area of research. Good morning and welcome, Janet.
Good morning to everybody, and I have to tell you, the view out of my window today looks a lot nicer than it did in January and March when we were getting going here, so I'm glad that we're finally over the snow, as I'm sure everyone else is. So we're going to talk about independence in elders, and I think it's something that maybe we take for granted, but let's get into it and we'll see where we go with it. Our goals for today are defining what independence in elders means. I want to talk a little bit about the new face of aging, because the elderly that we are working with right now, as we baby boomers, and I'm one of those folks, as we age, we are changing what aging is going to look like. And for most of you who are either baby boomers or going to be working with that population, it's going to be different than working with the aging population that you are working with now. And then we're going to have a review of the first 2 webinars that we did, assessment and intervention. So we're going to be revisiting those. And the goals are to become familiar with the basic income supports, resources, and services available to the elderly individuals and how to access them, and then to know how to link older residents with these resources while minimizing confusion and supporting informed decision-making. And I just want to reiterate, as with the first 2 webinars, I can only do this if it's interactive, and I want to hear what you all are thinking, so there'll be questions for you, and please participate. And Alicia will be the voice of you, and she'll be providing some responses as we go through. So first questions for you. So what is independence? So let me ask you the first one. How do you define independence? Let's give you a couple of minutes just to answer that question.
While we wait for some of them to give me some feedback, I define independence as being able to do something for myself. And so now some people say it's being able to manage finances.
Okay, manage finances, being able to do for yourself. Other thoughts?
No, taking care of my everyday needs and being able to handle your ADLs independently. I guess
Okay.
meaning without assistance.
Right.
But
Okay.
I think maybe sometimes you can still be independent and still get help.
Yeah,
Which is something that I'm learning.
Yes, yeah, and that's what we're going to talk about in a second. Why is it important for people to be independent, especially in our society? Why is that important?
So we have one more comment from how we define independence, and that's being able to live on your own with or without the help of others.
Okay, all right.
I think that says that. Why is it important? I think it builds self-esteem.
Okay.
The American culture values independence.
Absolutely.
It makes you feel valuable.
Right. All of those are so true. And the one about the American culture, in our culture, we socialize children from very early ages, almost from birth, to be independent. Other cultures sleep with their children in the beds. I mean, there's lots of controversy about that. We pretty much are always getting our children to be as independent as possible, putting them in another room even when they're small infants. We are planning for when they are leaving the nest. So in our Western culture, in America, to be independent means that you are a fully functioning adult. I'm going to ask you now, I see another one that says being independent reduces stress. It sure does. So do you all remember when you got your driver's license, for those of you who drive? What kind of feelings did that invoke in you? What was that like when you got that license?
I was excited but kind of scared and nervous, and my son just got his driver's license, and I'm feeling all those things all over again.
Right, probably even more nervous because it's him and not you. But what other feelings did you get when you got your driver's license?
Grown up.
Grown up? Freedom. Yep, everybody is saying freedom. Freedom, independence. You are on your own. Now, imagine that someone's going to take your driver's license away. How are you feeling now? Lost? Alone? I'm getting some of these up. Dependent on others? Yeah. So we have a lot of positive feelings when we got our first taste of freedom. Getting your driver's license, for those of us who drive, means that you are free in a way. Yes, you have restrictions and mom and dad on the car, but you're able to go and you're able to do things. And someone else is saying loss of control. So what we do when we no longer can drive, and this is this loss of independence, many times, when I'm working with families, they'll say, well, you can't let mom or dad drive anymore. And they don't understand necessarily why that makes mom or dad so angry and upset. And it is the exact opposite of that feeling of elation when we got our first freedom. We are now losing our freedom and we are becoming dependent. And that makes us sad. That makes us scared. And those are the feelings that happen to the elderly all the time. And we don't really realize the full ramifications of it. We just think, oh, well, I'll take you where you need to go. There won't be any problems. But it means a change in the way that we see ourselves. We see ourselves a lot of times we are reflected in how others see us. So if we have an event like all of a sudden we can't drive anymore, we see ourselves as being dependent, being a burden, and not having our control. And that is a very, very scary feeling for most people. So Independence means different things to different people. And Alicia, I've switched the screen, so at any time if I keep talking and if we have problems as we did in the first one where the screen doesn't move, you let me know. But right now it should say, what is independence continued? So it does, good. So independence means different things to different people, but the main ingredient is control. And it's control in a good sense, control over our lives. So when you were a teenager and you think back to that time, and most of the fights you had with your parents were probably about control. You can't go out of the house looking like that, so you wanted control in what you're going to wear, what time you're going to stay out, who your friends are, where you're going to take the car. So it's control over our lives. And that's what we continually want and we develop into. So we get to that stage where we're adults and we have control over our lives. I mean, we all have certain things we have to do, like pay taxes, go to work. But for the most part, we make choices every day. So when we lose that control, even little things, what we're going to do for the day, what we're going to wear, where we're going to live, what we're going to eat, all those decisions we take for granted. And when we lose that, it's very scary at best, and it can be debilitating at worst. There's been a lot of studies done in terms of how people adapt and to a nursing home facility. And one of the main ingredients is that sense of control, and it can be in minor things. So instead of saying, good morning, Mary, it might be, good morning, Mrs. Smith. We want to have respect. And instead of saying, Mary, here's what you're going to wear today, it might be, Mrs. Smith, what would you like to wear today? Even if we have someone who has dementia, we can offer them a choice. We can offer 2 outfits. And even just being able to say, I want to wear that one, or just pointing at something, we still have control. Also in being able to choose what we eat. So not just being served something, but having a menu, making our own choices. So for the elderly, and even in your residences, in being able to give them as much control as possible. And I know a lot of you probably have, tenant associations, getting people involved in that. There's certain things that they can make the choices over. And that's really important as we age, to maintain as much control over our lives as possible, because that means that we're still independent. Independence is also freedom, as we've talked about. So we see on the screen autonomy, self-respect, and dignity. So how do you define? Go ahead.
Janet, it didn't turn.
Okay, so you're not seeing it?
No. It says, what is independence continued? Independence means different things to different people.
Okay. That was the last screen. Did it change now?
Good. Yep.
Okay. All right. So, so what is autonomy? You see it on the screen, but give me your own definitions of autonomy, self-respect, and dignity.
I very honestly have not used, I've heard the word used in conversation, but I can't say that I actually know the definition of it without looking at it.
Of autonomy? Okay.
Yes.
Anybody else? Any other thoughts? Self-respect, dignity? These are words that we use all the time. Autonomy is a big, okay, we're getting some answers in there, I think.
Here we go. So some of our participants say that autonomy is responsibility, the ability to make choices for yourself, which is autonomy, dignity, being treated respectfully like a human being should be treated, and don't be treat people differently due to age or other circumstances.
Right. Good. Very good. So we are autonomous, and again, the comment about American culture, in many cultures, especially Asian cultures, autonomy is not valued as much as it is in our culture. Our culture values autonomy, being our own person, freedom to make our own decisions. In Asian cultures, and this is a good thing to understand, if you have residents in your facilities that come from other cultures. In other cultures, Asian cultures especially, it's not about autonomy, it's about family. So decisions are made not because of what I want to do, but what is best for the family. So it's a different way of looking at how we conduct our lives. But in our culture, being autonomous, being able to make our own actions, the freedom to be able to do that, that's very important in our culture. Self-respect, having the ability to say, I like who I am. So esteem for ourselves. When we do something bad, we might lose our self-respect. But as we age, we become less autonomous, so we have less choices. We might lose that esteem for ourselves because of that. And then dignity. So it's very important for people to maintain that dignity, to maintain that self-respect. So our bearing, our conduct, our speech, all of these go into how we feel about ourselves, how we see ourselves mirrored in other people. And as we age, we become less autonomous. It can affect our self-respect, our self-esteem, and we start to lose dignity for ourselves. I mentioned earlier, and this has been always one of my biggest gripes, and I remember when I ran adult daycare, sitting down with my staff, we assume that it's okay to call the elderly by their first name. And that takes away that dignity and self-respect. We want to ask, it's like when you meet a new boss for the first time, you don't go up and say, hey, Henry, how are you? Or hey, Susie, how are you? It's always Mr. or Dr. or whomever. And I think when we are working with the elderly, that we need to give them that choice. May I call you? Hello, Mrs. Smith. May I call you Mary? And usually people want that closeness, but we should never assume. We should always make sure that we are giving people that control, even it may seem like something very minor, but that control just to be able to say, this is how I want to be called. Okay, I'm going to flip the screen now. Hopefully it's flipped. Yes? Okay, good. So what happens when we lose independence? That's a question for you folks. What happens when we lose that?
Some go into a depression.
Yep. Absolutely.
Or they feel like they're a burden to others. We lose
Okay.
a little of ourselves. One person said anger,
Right.
We get angry, and loss of self or give up.
Right. Okay, good. And these are all legitimate feelings that any of us would have. You lose your self-identity. I think we ignore this in the elderly, though. So, and we ignore that this is how they may be feeling. For us, it may just seem like a natural transition. Think about our elderly relatives. Well, mom gets angry when I try to do things for her, and I don't understand that. Well, it's because perhaps mom is feeling angry at herself because she can no longer do what she needs to do for herself, and feelings of loss. But we ignore it. Why do we ignore this loss in the elderly? That's the next question for you all.
Maybe because we think, one thought is maybe we think that we can just make it all better.
Okay? That's very good. Other thoughts?
Oh, because some of our people say, you lose self-identity, and we feel it's the next step, and being impatient.
Being impatient, right.
Or we can't totally relate. And it takes some time and patience to give them the opportunity to make decisions. And, and sometimes, unfortunately, our lives are busy also, and we don't take the time. And we ignore it because it's not affecting us directly.
Right. And I think it's because we see this as a natural part for others. But do we see it as a natural part of aging for ourselves? And most of you probably would say no. We can't kind of imagine that time for ourselves, and we will all go through this. And it's really putting yourself in the other person's shoes to be able to think about how is this loss, affecting this person, instead of just saying, oh, well, it's time, why is she just being like this? And being impatient because, gosh, we got busy lives, and we've got to pick up the kids, and we've got bills to pay, and now we got to pick up mom from daycare, or we've got to do whatever, but we ignore it. And I think it's easy to do when it's somebody else. It's putting yourself in their spot and saying, how am I going to feel when it's my time? And that's one of the things that I've always taught my students, because when I'm working with clients, it's not about me, it's about trying to understand how the situation is affecting that person. And sometimes just asking them, how are you feeling? You can't drive anymore. It's making you angry. Just getting into their heads and empathizing with them can make all the difference in the world. Okay, changing screen again now. So hopefully we see this. So when we lose independence, we can have some physical and mental losses, forgetting appointments, making day-to-day tasks, having difficulty climbing stairs, getting in and out of the bath, unable to open jars. How frustrating is that for any of us when we can't get a jar open? Thank God I have a husband that I go to, and I say, here, that's his job. But when he's not around, you're ready to just smash the jar half the time. But just being able to do something as silly as opening a jar independently is important. No longer able to walk long distances, maybe having some vision problems and less control over our emotions, less physical energy, less flexibility, having hearing problems, less ability to move easily, memory problems, lower levels of stamina. All of those things combined can be very depressing. When you're no longer, you know that I can't even get in and out of the bathtub by myself. Those sense of loss of independence. Other things that we may have, and again, changing the screen now, social loss. How about the ability to just say, hey, you want to go out to lunch or to dinner, and you can't do that. Maybe you like to play a sport, no longer able to do that. Going to parties, visiting places, just having the ability to say, hey, I'm going to get out of here and take a ride. I'm going to go down the mall. Well, no longer able to drive, so going down the mall, going out to lunch, now becomes a major expedition. You have to arrange transportation. You have to maybe have someone go with you to help you walk. So all of that loss of control just adds up. And then eventually we have that emotional loss. And all of those other things lead to frustrations, feelings of uselessness. And in our society, I keep coming back to that, but in our society, we need to be useful. In other cultures, the elderly are revered just for their wisdom, and that's their usefulness. But in our culture, it's not necessarily true. Many people can't wait to get to retirement. I think we probably all would say, how many more years? Alicia and I were just talking about that yesterday. How many more years can I till I can retire?
I'm giving my 17-year notice.
Yeah, right. And I'm closer than you are. And it seems so great. And I've worked with people but once we retire, we have this big part of our lives that's taken away. We have, going to work, no matter how hard it is some days, especially this past winter when it's really nasty out and you don't want to get out of bed. But that makes us feel useful. I have a purpose. Sometimes I wonder, when you go into Walmart and you see the greeters and they're in their 70s or 80s, or they're cashiers, maybe some folks are there because they need some extra income. But I think a lot of these folks are there because it's feeling useful. Again, I have to get up. It's a purpose for life. I have to get up. Someone's expecting me to be there to do something. So that's really important for people as they age to still feel useful, still feel that they're contributing to their families, to their friends, to their community, to society. With that loss of independence comes sadness. So this is all part of loss of control in one's life. And anger. And we don't understand sometimes, why are they angry? Why is this person being such a bad person here? Why do they yell at me? I'm only trying to help. And it may not be, again, sometimes you have to take yourself out of the situation and not personalize things, because it's not necessarily you that they are angry at. So flipping the screen here, just to let you know that. So the typical reactions to loss of independence then, and they're complicated. Not everyone's going to feel this. We're going to go, it's kind of like grief. It's not linear, where we go through one thing and then eventually we come to acceptance. People go back and forth with these feelings, but there might be fear. Fear is usually where we start with things. Frightened by their new vulnerability. Wondering how they're going to manage on their own, feeling overwhelmed. Then they begin to expect family and friends, are they going to be available for them, and becoming overly dependent upon them. But fear is one of the things that we all experience at times. We may tell ourselves it's something else. We may transfer that fear onto others. And say it's, it's their problem, they're making me feel that way, but underlying it's our own fear of what is coming next. Then people get angry sometimes, angry that they're no longer able to manage on their own, angry that, they have to depend on their loved ones. I can relate to this kind of in a very silly way, but my husband is much more physically active than I am, and we used to cross-country ski. And I'm pretty competent in most areas, but boy, I could not stay up on those skis. And I was really great at making snow angels. And I saw a side of myself when we used to cross-country ski that I never knew. And my husband, he would laugh. Well, one of the things that would happen is when I'd fall down, he'd laugh at me, and that didn't help things. But I used to get so darn angry, and it was because I couldn't control it. I wasn't able to master something, and I'm used to being able to do that. And that's a really silly example of this, but that, for me, it brought home to me what it's like when you can't do something, how frustrating it is. And maybe
Janet,
you all have... Go ahead.
We're not on the... we need to move forward. We're still on loss of independence continued.
Okay, let's see. Okay. Can you see it now?
No.
Okay. Not sure why it does that.
Okay, now we're there.
Now you're there? Okay. So, again, I'll tell you when I move the screen, and just say we haven't seen it yet. So I think sometimes it's the time period that we're on it. Okay, so guilt. Guilt is another, and I think that the elderly folks often feel guilty, and that's why they refuse help from family and friends. They don't want to be a burden, and even you may tell someone you're not a burden. When you lose that independence, you feel like you're a burden to people. And then confusion. Sometimes they feel confused about needing help, and how long, and they really long for what was. So all of those things can be kind of typical reactions to the loss of independence, and sometimes we don't understand that. All right, I'm going to flip the screen now. Seeing it?
Mm-hmm.
Did it flip?
Asking for help.
Yep, very good. Okay. So how many of you are uncomfortable for asking for help, and why are you uncomfortable?
I personally am getting better at doing that. Quite a few of our participants are uncomfortable asking for help because I think sometimes we put it that if you ask for help, that means you're incompetent or incapable.
Right.
But what I've found is that I'm okay asking for help now on certain things. Some of they have feelings of inadequacy. They don't want to be a burden. Embarrassed if you're unable to do something
Right.
by yourself. Oh, worried that folks will think you can't do it. One says they're just weak. Or one of our participants says, I'm always the one helping and do not like to ask for help, which is kind of ironic because we want to help someone, and yet we ourselves don't care to be on the recipient. One of our participants says they don't know if someone else has the time or wants to help them, or fear of rejection.
Okay, yeah, all of those feelings. So think about all your residents. They are feeling exactly the same thing. I see another one that came up says, don't want to bother others. Well, guess what? Those feelings don't change. When you get old, they just get intensified because you have to ask for so much help. So when we are younger and we're able to do things, I hate to ask for help. Can you do this for me? Can you take me someplace? Or can you feel like you are a burden to others. You feel like you're bothering people. So we are willing to help because I think when you help others, it gives us this feeling of self-worth. But we are so fearful of asking for help ourselves for all of those reasons. Another one says needy. Yeah, you don't want to appear needy in front of people. And again, guess what? This is what all of those folks that you're working with, that's what they're feeling when they need to ask for help. Okay?
I've experienced this.
Go ahead.
I've experienced this in the professional arena, and I'll give you an example. I had a situation where I have this quite a bit where people say, they start off with, I know you're busy, but, and this is my response, yes, I am busy, however, I am there to help with whatever. So it's even in your professional lives as well as your personal, people don't like to ask for help because you think that someone is too busy. But my suggestion is don't assume that someone is, too busy. They can always say no, and that is their option.
Right, yeah, and I think that makes us feel bad sometimes when someone does say no, or we think that, maybe they want to say no, but they don't want to hurt our feelings or whatever. So most of the time asking for help we don't do it because it's our own stuff. We make a lot of assumptions. So there's our own feelings of loss of having to do that, and then of being a burden to others and not wanting to appear like we can't do something. So again, all of those feelings that you have as a younger person, you are carrying them over as you are becoming an older person. So some elderly may be are more comfortable asking for help, because again, we cannot say that all elderly are the same in everything. You have to be aware of the elderly folks that you're working with that are not. And we have to help them to be able to ask for help. You know those residents. Those are the ones that you will say, can I help you? And they'll, oh, no, I'm fine. And you know that they're not fine. And building that relationship, building that rapport with them, assuring them that taking the help does not diminish them in any way and is not a burden to you. So not just saying, okay, well, I asked and they said no. And I think there's a comment coming up, Alicia, because I get some of those too.
It says that's why. Oh, the next step. The way we came into this world is kind of how we're leaving the world. Yeah, you're right. That's a good analogy. You know, we come in and we are reliant on our parents and others, and you know, towards the end, that's some, not all though. And it's like you said, you can't classify, you know, everybody as the same.
Right. It's up to us to really figure out how we can help people who are afraid or are reluctant to ask for that help. Okay, I'm changing the slide now to say coping with loss. Yes?
No.
Okay.
We're still on asking for help.
Okay.
We're asking
technology.
for help now so that it will change.
Okay. Going to go back and forth till we get it here.
I must not like when we pause on some. Oh, there we go.
Okay. Yeah, I think it just takes a little bit when we're talking and we pause for a longer period of time. So, coping with loss. Being patient. This is really for us. Being patient with them. It takes time for people to acknowledge losses and to understand how that's affecting their life now. We don't want to say we can't do anything, and that's just human nature. And we think that, oh, we will be able to do it again. And sometimes it's a very hard pill to swallow when we know we can no longer do something. Helping them to understand that losing independence is a common experience as people age, and it's not a personal failure. So we never think, usually everyone goes through this. It's usually something's wrong with me. It's my own personal failure. So helping people to understand that that's not true. Helping them to recognize their feelings and that it's okay to feel sad, it's okay to be frustrated, and not getting mad at themselves because they are doing that. And not being mad because they can't no longer do what they used to do. Try to get them to listen to your suggestions about how to make things easier. And sometimes we need to start very small with that. So we rush in, we want to fix people's problems. But again, independence. Let's engage them and ask them, how can we fix this? What's your ideas about fixing this particular issue that you're having? What do you think we should do? That brings back some control. That brings back independence. And it's much easier for people to accept help then if they have control in choosing that help and came up with the ideas themselves. Trying to help to maintain relationships with loving and caring friends and family. Relationships are really important throughout our lifespan. And trying to work out what they need and, again, trying to encourage them to accept it. But I really think that all comes into feeling as if they have a decision in terms of what they want to accept. And usually we go with small stages. You need help, maybe, let's get you a cane. Let's try a walker. And then we move up to other things. Maybe you need help, cleaning your home. Or maybe you need help with personal care. But one step at a time to get people to accept it. All right, changing the screen now. Yep, okay, good. All right, I want to kind of shift gears a little bit and talk about how people are changing and how aging is going to change. So some terms that you may hear. So when we talk about aging from a theoretical perspective, we talk about senescence. And senescence is a normal decline in organ systems that take place after age 30. Yeah, I know. We don't think about age 30. Maybe they did have it right back in the 60s that 30 was old age. But up until that time, our bodies are really building things, and then after that, we do have some normal decline. Certain systems, if we stay active, if we watch our diet, all of that, we can continue to maintain for a long period of time. But in terms of theory and how biologists, medical profession look at it, we talk about senescence. Over the last 25 years or so, everybody was old. We just categorized old people in this arbitrary age of 65. In this country, 65 was considered old basically because that's when people got Social Security benefits. Now people are, no longer eligible for full benefits if you're my age till 67, I think, and 3/4. And the younger you are, probably the older you will be when you can get full Social Security benefits. So that definition of 65 as being old is kind of still in our collective psyche as a society. But what we really see is three categories. And for those of us who are in the business of studying aging, we have really different perspectives. And I think these categories are also going to be very malleable and might change as we go through. So we have the young old, individuals age 65 to 74. Those we consider, when people tell me that they're old and they're in that group, they're not. We don't even consider them really old age, but that's the group we call the young old. Still pretty active, usually in good physical condition for the most part in general. Then we have the next category, which is the old, and those are ages 75 to 84. And then we have the folks that are the oldest old, and that's individuals over 85 years of age. The category in the United States that is increasing the most from all age groups is this oldest old. So we have more individuals now who are over 85. We have more individuals who are over 100 than we ever have had in our history before, and that is the fastest growing segment of our population. Changing screens. Yes, see that?
Lifespan.
Good, very good. All right, so let me just give you some more definitions here. We also talk in aging about life expectancy and lifespan. So life expectancy is dependent upon when you were born, and that will give people an idea of how long you are going to live. So life expectancy for someone who was born in 2015, 2014 is around 82 years. This is what, if you go to buy life insurance and they have actuarial charts and they look at how old you are when you were born, this gives them a rough idea of how long you're expected to live. Kind of a morbid business they're in, but this is how they base their rates. So if you buy life insurance when you are in your 20s, it's much cheaper than if you buy it when you are in your 60s or 70s because you are getting closer to that time period when you're going to pass away. So that's individual. Lifespan, however, every species on the planet has a maximum lifespan. So our dogs, our cats, how long is the upper limit? And for humans, our top limit right now is 120 years. So most people don't live to 120 years. We have more people getting closer to that top limit, but scientists tell us that that's about how long we are programmed as human beings that we could possibly live, okay? There's been a lot of talk recently that in the scientific community that they think that top limit, our lifespan over the next 100 years, has the potential of increasing. I've heard crazy numbers, 200, potential to 500 years old. But right now, no matter what you do, you're probably not going to live much longer than that top limit. Life expectancy, so lifespan is kind of, we can't control that. Our life expectancy we have more influence over, and it's influenced by advances in medicine, public health, our lifestyle practices, the quality of our diet, how physically active we are, avoiding tobacco. So all of those things go into how long we individually are going to live, our life expectancy. If you live in poverty, if you were born into poverty, your life expectancy goes down because you might not have had adequate nutrition, medical care when you were an infant. So all of those things go into that, how long we're going to live. Okay, changing the screen. Hopefully it changed.
Yes.
Our current life expectancy right now for males is 76.1 years, and for females is 80.9 years. And this is just average. The interesting thing is that we expect the United States to be number one in terms of how long people live, and we're not. We're 36th ranked in the world. So other countries, there's 35 that are above us in terms of our world ranking in terms of life expectancy. So that's just gives you some food for thought there, because we always expect the U.S. to have the best medical care, the best food, and overall, there's still lots of areas where that's not true. So the World Health Organization ranks us as 36 in the world.
Do you think maybe,
why are we?
Well,
Go ahead.
I was going to say, do you think that maybe part of why we were down there in the 30s is because maybe we don't make the best choices, even though, we might have the other things that, you know what I'm saying, recreational uses, and, that why our why we're not up in those numbers.
Yeah, and, there's lots of research out there, lots of different theories why. We're also workaholics in the United States. Other countries, when you look at some of them that are ranked higher, and especially, the Nordic countries are usually ranked way higher than we are. And part of it is because of, our stress in our life. And I think there was a comment, Alicia, that came up. It
says the U.S. still has huge disparities related to income and race that impact life expectancy.
Yeah,
we are
absolutely.
The melting pot. That's what we've been known.
Yeah, yes. And the whiter you are, the richer you are, the better chances you have of living a long, healthy life. And that's still true in the United States. And so we have a lot of work to do, in my opinion. Overall, as a society, we are living longer. So if you, around 1900, so a little over 100 years ago, life expectancy was around 50 years of age. If you go back and you look at pictures of people from the 1800s, early 1900s, and you look at them and you would think, oh my God, that person has to be maybe in their 70s or 80s, they're wrinkled, no teeth, they look very old. And if you actually knew how old they were, they probably were in their 40s or 50s. So we did not live as long. It's only in the last 100 years. And why we live longer overall is because better nutrition, better health care. One of the things, two things that really have helped people live longer, there was a lot of infant mortality. So vaccines and antibiotics, probably antibiotics have been one of the biggest reasons why people have lived longer. Better hygiene, better, not just our personal hygiene, but better sanitary conditions. just taking sewage away, not having, festering epidemics, that kind of thing. So this is kind of the reasons that we've been living longer over the last 100 years. I've changed the screen again. We've also had better working conditions. The other personal thing that we have done, and maybe more so in the last 50 years or so, 60 years, is having a better understanding of how we behave individually, taking responsibility for our own health, not smoking, for example, exercising more, controlling our high blood pressure, cholesterol, diabetes, all those kinds of chronic conditions that lead to an earlier death. So we're not necessarily, as a society, there yet. We still have a lot of obesity in our society. We still have a lot of issues in our society, but we all know and have a better idea of how our personal behavior impacts how long we're going to live. So that's another reason that we are living longer. Changing the screen again. So the top 5 causes of death right now in the United States: coronary heart disease, although we've made significant strides in that area, it's still probably our number 1 killer, and it's really, there's a disparity between males and females in this area as well. So we've done a really good job of knowing the warning signs for heart attacks for males, and not so good job for understanding that it is also the leading cause of death for females. It's not breast cancer or uterine cancer or ovarian cancer for females, it's coronary heart disease. And our warning signs are different, and that's where we still need to have work done there. Lung cancers are our next biggest reason, and this is still either related to some kind of work hazard. You've seen the ads on TV, usually by lawyers, for mesothelioma. That's exposure to asbestos, but also still smoking is one of the main reasons for lung cancers. And there's other, people get lung cancer and have never done all of those things, so there's always that slight risk. Stroke. So the same risk factors for coronary heart disease are the same risk factors for stroke. Alzheimer's and dementia are up there. That's why, for all of these, and especially for Alzheimer's and other dementias, it's really important that we have treatments. We find, if not the cure, at least we're moving in the right direction of having some idea of what's happening, but that's up there in the top 4. And then rounding up the top 5 is other lung diseases, so emphysema, COPD, any asthma. Those are the reasons that would be the other lung diseases. So those are the top 5 causes of death in the United States. Switch the screen. So consequences of living longer. So there's positives and negatives. I think if we asked anybody, do you want to live longer, most of us would say yes, maybe with a caveat of as long as I can be healthy. The whole world, actually, we are becoming a more aged world, not just the population in the United States. So the World Health Organization reports that some of the consequences of living longer is that the longer we live, the more risk we are for having dementia or Alzheimer's disease. And all that means is that if something gets you before you get to the old advanced age of, in your 80s, 90s, when you are more likely to have some kind of dementia, but if you die before that, so the longer you live, the more risk you are for those diseases. The need for long-term care worldwide is going to increase. And then they also point out, which was really interesting when I was researching this, is that the threat of maltreatment in old age is also going to increase. And that's kind of understandable as we have more folks in the world that are aging. We have only finite resources. So we're going to have some issues and problems that we are going to need to work on in terms of how we treat the elderly as we move forward. changing the screen again. What's the effects of aging population in the United States? And most of you might have seen that inverted pyramid example, where before we would have a regular pyramid shape, and on the bottom would be the young people. So we had more young people than we did older people. Now sometimes we see an inverted pyramid where we have less younger people on the bottom supporting more elderly. The actual shape, if we look at it, is not so much an inverted pyramid, but we see it's pushed in, where it looks more like a tube as it goes up. And all that means, kind of in a visual way, is that there's going to be less younger people supporting older people. So as we know now, the Social Security that you pay every month, and I think I've skipped a screen here. Wait, yep, there we go. Let me go back. Okay, I think I hit twice here. Let's talk about the positive things first, and then I'll get back into that. Sorry about that. So the positive is that we have the opportunity to live a longer time in healthy or old age. We're probably going to have a longer time in the workforce. Now, individually, that may not be a positive, but for society, there can be benefits from experience and wisdom of older workers, and everyone that's working is still contributing to the overall gross domestic product, the GDP. And you hear that all the time in terms of how well our society is doing. There's also the opportunity for caregiving for younger generations as well, and providing that wisdom. Now let me move on to the next screen and talk about the negative aspects. Most of the negative aspects are going to be financial. Can we afford an older, aging population? So as I said, I was starting to say, the Social Security that we pay in now, each individually, isn't going for us directly. It's to support the aging population now. Same with Medicare. We hear a lot of talk last 20, 25 years about something has to be done with Social Security. No one really wants to tackle that. But the problem is, as you have less workers, or if we have this cylindrical shape of our population where we have less or an equal number of younger people supporting a larger population of older folks, we're going to have less people paying into the system. That is why some changes to Social Security. So you can still do early retirement at 62. But before, when everyone used to be able to retire at 65, as I mentioned earlier, the younger you are, and you can go on to us.gov and to Social Security, and you can see when you can receive full retirement benefits, but that's increasing. So for me, I'm 57 right now. In order to get my full retirement benefits, it's 67 3/4 that I would have to wait. If you are younger than that, it's probably going to be pushed back even further until it gets into the early 70s. So the longer you push people back from getting those benefits, the more solvent the system can maintain. At least that's the theory. When Social Security, when Franklin Roosevelt back in 32 designed the system, the arbitrary age of 65 was chosen because most people weren't living to 65. So, and there was a lot more younger people to support all of those older people. So it was kind of an arbitrary age, but now it's really going to have an effect on us and as a society as we have more people who are living longer. Okay, change it again. So preparing for old age, we have to take personal responsibility. So the healthier you are as you age, the less burden you are onto others and onto society, and the more independent that you can maintain yourself, the less issues you will have. That's only common sense. The interesting thing, and I always ask my students, especially if it's an early morning class and they come staggering into class after a late night of studying. I always tell them, I'm sure they don't party, but I'll ask them, how many of you had breakfast today? And a few hands will go up. And I'll say, well, what was your breakfast? And it's usually the cup of coffee that they've brought in with them. Maybe they've had some kind of cupcake, muffin, but mostly they're living on coffee. And what I tell them is what they do as a younger person will impact how they are when they're an older person. So if they deplete themselves and don't build up a good, healthy self as a younger person, when they reach old age, they're going to have much more issues and problems. So that's something to keep in mind. The good news is that we can start improving our health at any age. Lots of studies that are out there in terms of our respiratory system, our cardiovascular system, watching our diet, exercising, even into old age, those systems can be, if not totally repaired, at least made better. So that's the good news for ourselves. Another big area is financial. Let me ask you this question. How many of you have figured out how much money you're going to need when you retire?
I have not figured this out, but I'm going to say that, when I was in my 20s, and my dad had the conversation, oh, you have to, 401k with your company, you need to get in, you need to, invest. And I'm like, yeah, I'm only in my 20s. Well, okay, now I'm in my late 40s. And it's like, I really, really wish I had listened. Some of ours says, two of our participants, that they have figured out how much it is that they need.
Good. And there's lots of calculators out there and whatever. Some of them, I was doing, again, some research for this. It's, there's lots of different factors as we grow older in terms of taxes, how much money we're going to be spent. It's also looking at what we expect our lifestyle to be like. All of us say we want to, golf all the time, go on vacations. That's our goal for retirement. The reality is, and this is kind of a shocking thing, about 36% of workers have less than $1,000 in savings and investments that could be used for retirement. So they might have some other kinds of plans, but personal money that they're putting aside. Other things that I have seen is that most American workers are like 1 or 2 paychecks away from disaster. So if something big happens or if they lose their job, they don't have enough money to survive. So as a society, if for the participants who have done this, great. We need to really think about how much money we need to have in retirement, as we don't know what will happen with Social Security, if it will be there. It probably will be there in some form, but the longer you have to be able to collect it. And most people living today, and you probably know this from your residents, if all they have is Social Security, then they're living at or below the poverty level. So unless they have some other kind of income coming in from pensions or things like that, and most of us don't have pensions anymore, it's all up to us, as Alicia said, to put money consistently into a 401k, then most people are not going to have enough money to live with retirement. The other thing is we are underestimating how long we have to live. So what we don't want to have happen is for our money for us to outlive our money. So we have to plan. It's better to have the money outlive you. So I think we underestimate how many years we need to plan for, and most of the estimates right now say we need to plan for about 30 years in retirement. So that's quite a long time. That's almost as long as our current working life. And it's a little scary when you think about that. The other thing that was we're preparing for old age, and I've talked with a lot of folks about as counseling them, is what are you going to do? So it sounds great to say I'm not going to get out of bed until 10 o'clock, and I'm not going to have to worry about the alarm clock, and I'm going to go golfing every day or fishing every day, and that lasts maybe a year. And people then need something else to do. So the other thing that we don't do, so we don't plan maybe financially well enough for old age. We also don't plan on how we want our old age to be in terms of our leisure, or perhaps, and what we see now are many people starting new careers, going back to school. I think as we continue to age and we become older and we're living longer and we're healthier, you're going to see more and more people start second and maybe even third careers. The other thing that, in terms of what we're looking at and many times also, and how it's going to change, is our relationships, having more relationships, or changing the way we look at marriage, perhaps. So there's lots of different things that are going to be coming in a new society as we continue to age and we continue to live longer. Okay, changing screen again. Two other areas that I'd like to talk about, and Alicia reminded me.
Yeah,
Go ahead.
It didn't turn.
Okay. Go back and forth until it does.
There we go.
Should say, okay, additional resources. Okay. Yeah, I think there's just a lag depending on how long I spend on the screen. So Alicia reminded me that we needed to talk about CILS, or Centers for Independent Living, and Life Centers. And these are two resources that may not be on the top of your list. Last time we talked about Area Agency on Aging and what the AAAs can offer, AARP. But these are really two areas that can provide a lot of support for the folks that you are working with. So Centers for Independent Living first, hopefully it changed. So these really started as grassroots efforts after the Americans with Disabilities Act in 1990. So they're community-based, consumer-driven organizations that provide information and referral, peer counseling, skill training, advocacy, and a variety of services based on individual needs. Each Center for Independent Living, or CIL as they are called, is community-based. So they don't offer all the same services. It really depends on what's needed in their communities. Their consumers are primarily disabled folks under the age of 60, but they are serving, more CILs are serving folks over the age of 60 now as well. And actually some of them are getting more contracts from their local area agency on aging. In the state of Pennsylvania, right now we have 25 Centers for Independent Living, and I put the source up there, and that, and if anybody wants that link, you can certainly email me after the seminar is over. But that will tell you, that lists all of the CILs in Pennsylvania and the closest one to your area. The independent living paradigm was developed by Gerben de Jong in the late 1970s. And what we saw was a shift from the medical model to being independent living model. So instead of putting people who were disabled, some severely disabled, in nursing facilities or other types of care facilities, or even if they had some kind of cognitive impairment, it was the whole movement to move them out into community and society. Back in the early 80s when I worked for the ARC of Northeastern Pennsylvania, that's when we were moving folks out of institutions, folks that had developmental disabilities. That was the big shift, to move them back into the community. So this has been going on since the 70s. And again, the Americans with Disability Act in the 1990s really provided that legislative protection for the civil rights of people with disabilities. So that's kind of the genesis of the Centers for Independent Living. Changing the screen now. So some services the CILs can offer, and again, you'd have to check in your area, your CIL, and to see what they offer, but there can be independent living services, so advocacy, and that's probably one of the main areas that they got started in, and that's what they continue to do today. Peer counseling, skill training, and information and referral. They're also, and this has been a change even for the CIL that is in my area of northeastern Pennsylvania, mostly did advocacy kinds of work, but now is getting much more into the actual provision of services. And they also have the contract from the Area Agency on Aging to do the assessment for waiver services in our area, and actually in the Northeast area. So they can help personal care, adaptations to the home, temporary respite services to relieve family members or caregivers, personal emergency response systems, you know, that electronic help button, help I've fallen and I can't get up, physical therapy, speech and hearing and language services, special medical equipment and supplies, non-medical transportation. Some even offer visiting nurses, cognitive therapy, counseling, community integration, socialization, and adaptation skills. There can be other home modifications, nursing home transition programs. So some CILs, again, contracted through the aging office. If it's not run right out of the local AAA, they might do the nursing home transition program, getting people who would otherwise be eligible for nursing homes and using that money for community-based services and moving them out of the nursing home. Financial services, our local CIL actually has financial services available, and they have a contract, I believe, out in Indiana where they do most of the third-party pay kinds of services. A new area that they're really getting into is autism services. What people are realizing is that folks with autism are aging. So we hear about autism services mostly for children, but guess what? Those children grow up, and there's nothing for them once they leave the educational system. So the Centers for Independent Living are really kind of taking a look at that, and many of them are having continuing services for folks that are on the spectrum. And then training programs. A lot of CILs have training programs to help get people back to work. So they offer lots of different kinds of services, and they're a wonderful resource in your community. You might know about the ones that are in your community, you might not, but it's certainly worth checking into. The other area that I want to talk about is life centers, and I've changed the screen again, and I'm talking a little fast to get through all of this.
Yeah. We have 15 minutes.
Right. So life centers. Actually, the federal term for life centers is PACE. What they are is a rural program for all-inclusive care for the elderly, but they're called life programs in Pennsylvania because we already have a PACE program, and that's our prescription drug program. So they're called life centers. So this program was established by Congress under the Deficit Reduction Act of 2005, and it's administered by the Centers for Medicare and Medicaid. And it provided initially 15 providers with startup funds to develop PACE organizations serving rural elders, and now it is in every state. What a PACE center is an adult daycare program where all services are provided through that program. So it is much more than the normal adult daycare program. So it's an integrated acute long-term care model for frail, disabled adults living in the community. In Pennsylvania, there are 17 providers of life care services programs who operate in 30 centers in 18 counties. So some providers have more than one center. So again, all-inclusive adult daycare programs. All medical care is coordinated, and most of it's provided at the center. So they would see their doctor, and most of the care is provided right there. The idea being that instead of having to drag the elderly person the folks who go to the life centers are usually pretty infirm, and instead of having to take them one place for something and someplace for something else, most services can be provided right at the daycare program. They have to be eligible for medical assistance, and they can no longer use their primary care physician. So the problem with life centers, and actually we looked at these, my research partner and I, when we did our last research grant for the Center of Rural Pennsylvania, this is the main issue with convincing people to go to a life adult daycare program, is that they no longer have the ability to choose their own physician. And again, loss of autonomy. But they can be a really big resource because they're able to keep people in the community. These folks that are attending these programs would definitely probably all be nursing home candidates, if not for the life center. So this is another great resource in your community. Okay, I'm changing again. Let's just do a little review of what we've learned, hopefully, from the last couple of sessions, if I've done my job. So assessment, we've talked about assessment, the active evaluation. It can be multifunctional, cognitive, medical. We look at functioning level, ADLs, which are basic activities of daily life. We also look at IADLs, so those secondary activities like paying bills and grocery shopping. We know that we want to assess for social and psychological functioning. We talked about the biopsychosocial assessment, and again, that's assessing the whole person. We talked about the functional assessment. How does a person function? So these two things together are really important. It's not just about looking at the deficits, but what can they still do for themselves? So assessing those ADLs and IADLs. We talked about the helping process, building a relationship, facilitating a positive action. Most importantly, we talked about the strengths perspective and looking for our clients' strengths rather than just deficits. We talked about being agents of change and how we can do that effectively, enabling people to work effectively as they plan, implement, and experience change, and keep increasing people's knowing of our skills and our limitations. We also last time talked about informal versus formal resources. Does anybody remember what the difference is between those?
I'll chime in on informal. Informal is like your neighbors, your friends, your relatives. Nothing like no contract set up. It's what's in a lot of them, or your church. Right there, informal, family, synagogue, church, friends, and formal, such as agencies. Right.
Yeah. So those looking at what informally can help folks, and then looking at the formal resources. And here again, when we talk about, to kind of wrap it up and talk about independence and bring it all together, people are much more likely to accept informal help than they are formal resources in many cases. We also talked about those eco maps, drawing those up to find out, the visual guide, to find out what family dynamics look like. Are they nurturing or confrontational? Looking for support systems, who's contributing to the community, who's in someone's life, as their significant friends, neighbors, sports clubs, spiritual influences, looking at the whole family unit, and then areas of deprivation where services need to be mobilized or strengthened. And again, I'm a big believer in the eco maps. A lot of times when I'm working with elderly folks, I'm listening to them and I'm kind of sketching out an eco map as they're talking about who is in their life and areas that they have deficits in. So kind of what have we learned? Remember Mary that we talked about early on? So Mary is that coming back to our friend Mary, who's the 82-year-old female that's been a resident in the elderly high-rise that you've managed for 5 years. She's developed a number of friendships at the high-rise. She's always been pleasant when approached, but lately you notice that she is more reclusive than normal. She appears to be more unkept than normal and maybe slightly confused. You're not sure if Mary has any family who live in the area. Her apartment is okay, but you believe she might benefit from some help. It's kind of not up to your living standards. When you ask her if anything's wrong, she denies it and gets angry, and she tells you to mind your own business. So that's our friend Mary. So kind of in the last few minutes that we have, so from what you've learned, what are you going to look for in Mary's case, using the tools that we've talked about? Give you a couple minutes to think about that.
One person says, has she been to her doctor recently for assessment of health changes?
Okay, so looking at that biopsychosocial assessment, getting that bio piece, the medical piece, absolutely. Other thoughts?
Oh, what changed in her life, perhaps? Was it anything medical, family? You know, did she experience loss, whatever that loss was? Like we talked about today, you know, loss can be driver's license, but it can also be a death in the family.
Right.
Or the ability to do something. So, you know, did she experience a loss of something?
Right. Right. We'd also want to look maybe at that functional assessment. What can Mary still do? We want to assess her strengths. We want to look at that strengths perspective. Maybe develop that eco map. Sit down with Mary and talk about who is in her life. Sometimes I think with residents, maybe in your situation, you get to know some very well, and others who are maybe not as social or not as willing to disclose who's in their life. You may not know exactly who's available to help. Perhaps there's a church, even if they don't have any family, that might be very or had been very involved with their church. And many churches have programs where they'll reach out and do some things. So looking at all of that, building that relationship with Mary, starting from the strengths perspective, not just looking at the deficits, but looking at Mary's strengths, and then developing ourselves to be able to function within that helping process. We'd also want to look at informal versus formal services. So what kinds of things can we get for Mary in her community, even from her neighbors? Many neighbors, you know, be happy maybe to go over, provide a meal, sit with her while she has her lunch to make sure she eats, family, church groups, and then assessing formal resources, AAA services, case management, homemaking, maybe services through the Center for Independent Living, medical care, as one person said, the primary physician, you know, getting those folks involved to be able to pull in. We want to pull in as many things as we can to help our residents. We want to envelop them in a good caring network. And again, today, getting Mary, the other piece, and probably the most important piece, is asking Mary what kinds of things would she like help for. And sometimes it takes some convincing, as we've talked about, but it's really helping her to maintain her independence and her sense of dignity, self-worth, and autonomy for as long as possible.
How important do you think it is for the environment of where you're going to have these conversations? Because I was a service coordinator, and, you know, to visit a resident, you know, to just do the knock on the door and say, hi, I was in the, walking down the hall, I stopped, versus having them come down to the office.
Well, I think that you have to assess it for each individual. If it were me, I would do the friendly knock on the door. Sometimes being called down to the office can have some negative connotations for people, a kind of quote unquote being called down to the office, kind of like being called to the principal's office. Maybe establishing some kind of informal things, a coffee hour, a lunch once a month or once every other month, where you can start developing those personal relationships with the folks in your building. So you're not just seen as kind of the manager and the person who may have the ability to throw you out if you don't pay your rent or your apartment's not clean enough. But developing those relationships, I think, are really important. But I would also do, and that's just me, I would do the knock on the door and say, Mrs. Smith, how you doing today? How's everything? A lot of folks may invite you in, and if you have time, to go in for a cup of coffee. I really think it's really important to develop those relationships early on. So I don't know, Alicia, maybe, you have a different perspective having done this, but...
No, that's how I did, but I do agree. It's, and it's how long, you're at the building, you get to know them, but trying to get to know them before they might actually, be in this situation, I think is very helpful also.
Yeah. And again, having done these kinds of, I've never done residential services, but I think I would start when they're pretty when they first move in, but maybe having coffee hours where, you kind of facilitate discussion, or just having it really informal, coffee and cookies and tea and that kind of thing, tea once a month or once every other month, where people get to kind of know you on a more personal level. And I don't mean disclosing your personal life to them, but see you as a different part of their life, and it kind of as a resource for them, I think would be really helpful. My final thoughts is we're almost done here, and these are the things that I try to live by, is respect for the elderly. Respect, respect, respect. And I think that is where we start. When we think about the strength perspective, it's really respecting that these folks have made it to old age. They've been independent adults. We want to continue to promote as much independence as possible. And again, even if it is only in minor ways, but where we're able to be independent, then we respect ourselves. I think that you need to view your work with the elderly as a privilege. For me, being able to be a part of people's lives, especially as they become more dependent and infirm, is a real privilege to be allowed to help people. Continue to learn, and also, be proud of the work you do. I'm sure that you are all wonderful at the jobs that you do. I've always heard when people find out that I work with the elderly, you must be a saint, and certainly I am no saint, but I think that it does take a special person to want to work with people in any capacity, and especially those that can be difficult at times, for all the reasons that we've kind of talked about. So I think that you all should be patting yourselves on the back and really proud of the work that you do. And finally, thank you for your participation in these 3 webinars. I hope that you found them useful. I've enjoyed doing them with you. Thank you for your participation. I like to do things interactive, as you know, and that's my information. Please contact me if I can ever be of help to anyone. So that's it for me. Thank you very much.